Hello, my name is Ali Alami. I'm a consultant surgeon working in East Kent, and I was a fellow at Guy's and St. Thomas's. It is my absolute pleasure to introduce to you the speaker for tonight is Dr. Varun Rai, who's a consultant ENT surgeon based in New Delhi in India. He has very kindly given us a talk previously with regards to salivary gland management. Today, he is giving us a talk on surgical management of snoring and sleep apnea in adults. Just in terms of his background, he's done a fellowship in Italy in sleep surgery, and therefore I'm really looking forward to this talk. And over to you, Dr. Rai, for some words of wisdom.
Thank you. Thank you so much for having me. Perfect. So let me just start off without much ado. So just the first slide is and you can see how it can wreak havoc. And yeah, you can see Marge right there trying to cover the noise with her ears, going all around. Exhaust of the which is an induced apnea, so to speak. So it was once considered a sign of prosperity. Now it's proven to be a harbinger for various diseases. And so now we've started taking this seriously. And the incidence, according to various meta-analysis and studies, is quite high. And this is a study that I found of a meta-analysis over the years. And we see the incidence, which has risen recently. Now in the UK, the 13% of the adult males do suffer from obstructive sleep apnea and 6% of the adult females. And recent evidence does suggest that 85% of the people are undiagnosed and therefore untreated. Now, this has a huge impact, financial implications on the NHS as well. And without getting too much into the nitty-gritties of it, the take-home message for this slide is basically, if you treat sleep apnea, you save a lot of money for your government. It increases the patient's lifespan and the productivity of the patient, as well as the partner who gets a sound night's sleep, and eventually reduces the burden on the healthcare system. So it is a thing which is to be taken quite seriously. So understanding sleep apnea. So what really happens at night when you fall asleep, especially when you lie on your back? Now, the first thing was the normal airway. But once the soft tissues of the neck collapse, that's when you get your apneic spells. And that's when you try to push air from above, it just opens up the airway, and that's the principle of the CPAP machine. So just a brief overview about the anatomy which is relevant to us. So we have our entire airway system starting from the nose, the nasopharynx, oropharynx, hypopharynx, and the larynx, and heading down into the trachea. The trachea and the nose are the non-collapsible part of the airway, which can only really give rise to static obstructions. The majority of the dynamic obstructions is the soft palate. And it's, I just need you to make a note of this slide. We have the two, the levator and the tensor veli palatini, and which is responsible for your soft palate elevation. And basically, if you stay below this line, you're never going to cause velopharyngeal insufficiency. Regarding the symptoms of the patient, I've just color coded them. The ones in yellow are for the mild sufferers. Ones in orange, you try and the symptoms become slightly more sinister, where you have gasping, breathing pauses, and night awakenings. And of course, you have your consequences, which are high blood pressure, cardiac issues, chest pain at night, which are really, really alarming. For your clinical spectrum, you have the entire range of breathing, which is from normal to your severe sleep apneics. And you have a lot of subtypes along the way. And you have the occasional snorers and the regular snorers, which have just been differentiated. And as you see below, your desire of the patient to get treated, occasional snorers, really transcends to need of intervention as you head into the apnea. So diagnosing obstructive sleep apnea was really quite simple earlier, where you would have the history questionnaires, you would just do a PSG or a home-based sleep study because you were really dealing with a single cure option. And this was an example of those questionnaires. These are all available online. We have the Epworth Sleepiness Scale, which was in vogue for quite a long period of time. Now we have the Stop Bang questionnaires. And once you would do the polysomnography, which was really done by our physician colleagues, you would get this sort of a report where you would get the total time spent sleeping, you would have your snoring, you would have your apnea and hypopnea index. And apnea is basically a cessation of breathing, and hypopnea is less than 50% of your breath, chest movement on breath. And this was calibrated as an index, which was used as a measure of severity for your sleep apnea. We had divided them as 5 to 15 as mild, 15 to 30 as moderate, and greater than 30 was categorized as sleep apnea, severe sleep apnea. And we would really treat them in a single way. If the physician was the contact doctor, he would prescribe the CPAP. If the patient had the ENT doctor as a source of medical opinion, he would just undergo palatoplasty, which was really in vogue in the 80s. Now, a nasal surgery was done with in adjunct to your UP3. So, but over the years, we saw that UP3 alone gave a 50% long-term success rate. And when combined with nasal surgery, yes, it did go up to 73%, but we're not really satisfied with those results. Where did we go wrong? We now know that it is a dynamic and complex condition which you cannot have a one-stop solution to all. We obviously needed better diagnostic tools to really find out what was happening. And we had to understand the obstructive forces at play, which were really invisible to the naked eye just on clinical examination without specialized tools. So we knew that the PSG and your questionnaires quantifies the problem. We know that there is a problem, but we had no information about which site of the nasal of the airway was really causative of the problem. We did not have any idea about the types of collapse which really occur during sleep. And more importantly, we had no correlation with the sleep cycle according to the degree of collapse or the sleep apnea. Now, it has now been well established that sleep apneas can really happen during your rapid eye movement sleep phase or the non-rapid eye movement. And we also knew that there were higher dangers associated with REM apnea. However, we know that REM sleep usually occurs later in the night, and CPAP compliance at its best was about 70%. And the patients would usually use it for 3 to 4 hours at night, and that would not really cover your REM sleep. So these patients were not getting treated or getting any sort of relief with their CPAPs. So surgery should be considered despite the BMI or the AHI of these particular subset of patients. So when we talk about the types of obstruction, we have divided them into the static and the dynamic collapse. Static is something that you can see in your OPD. You look at your nose, tonsils, skeletal malformations, your lingual tonsils, and that's really right in front of you. The dynamic collapse is basically a collapse of your normal structures during sleep. So these were divided into three levels, which was behind the palate, behind the tongue, and your laryngeal levels. So really what we were talking about was the causes of dynamic collapse. Why were they happening? Well, just going into a little bit of the physics, we have the stalling forces, we have a low pressure above, low pressure below, and a high pressure because of increased resistance in the nasal part. And that causes a collapse of your middle segment, which leads to your snoring or sleep apnea. Well, you would also have and this is a video I've just taken off the internet and found it really interesting, where when the patient would be breathing in through the nose, the soft palate would be elevated, your tongue would be ahead, but once the patient opens the mouth, there is a unstable airway, and which leads to a vibration of the soft palate, leading to the snoring as we know. We also have found out that the nasal ventilatory reflex, wherein the decrease in nasal airflow would leads to less activation of the nasal receptors, and consequently there would be inhibition of the muscle tone, which would lead to a flaccid, soft palate and your tongue, which would lead to snoring itself. We also now know about the role of nitric oxide, which leads to a reduced ventilation perfusion ratio in the lungs, leading to a reduced oxygenation, which really becomes quite troublesome. So, the present day sleep surgeon has the following investigations in his armamentarium. We obviously, the basic clinical examination is a must. We have our X-rays for cephalometries. We have awake fiber optic laryngoscopy, specialized laryngoscopy, sleep study. But now we also have the sleep MRI and the drug-induced sleep endoscopy. Nasal cavity is self-explanatory. In your throat examination, you have to pay particular attention towards the dentition, which I would just like to point out, your tongue position and your tonsils. And your tongue position was, there are various scales to classify it. We have the Friedman tongue position, you have your Mallampati score. Well, all these were basically for our anesthetists, but they have a huge implication in yeah, your sleep apnea as well. Well, cephalometric evaluation is really, really advised in cases who have a visual hypoplastic or a hypoplastic maxilla or a mandible, where you would really get all these measurements and you would plan out your intervention in other ways, which I shall be discussing in a bit. Your awake fiber optic laryngoscopy was basically done, it's either in a sitting or in a supine position. And the Muller's maneuver is basically a reverse Valsalva. You ask the patient to pinch the mouth and the nose, you ask the patient to breathe in, and that would slightly stimulate the snoring, the sleep apnea conditions, and that would give you a very nice indicator about what the problem really was. You would also have the end expiratory pressure, where you would ask the patient to basically just release all the air from the lung and then hold it, and you would rightly see the tongue movement at the end of this maneuver. Based on your levels, which I discussed about the retropalatal, lingual, and the laryngeal, for purposes of classification, there was a vote classification which was very much in vogue, where we would have 4 levels. We have the velum, the oropharynx, the tongue base, and the epiglottis. And each of these constitutes a clear-cut surgical area of interest. And however, now we have the UDICE model, because we really need to take care of our static obstructions as well. And there are different patterns of collapse when associated with the dynamic conditions. So this is the model that we follow now, and they had a very good idea of characterizing the percentage obstruction as well. Drug-induced sleep endoscopy is basically done in the OR, and where the patient would be sedated with either propofol or dexmedetomidine, and it provides a better understanding of the patterns and the levels of obstruction multi-level OSA. Of course, there is a lot of criticism because it cannot replicate natural sleep, and of course, according to different stages of anesthesia, different patterns of collapse are observed. So the next investigation was the sleep MRI, where the patients would be asked to sleep in the MRI machine, and the MRI would really, really continuously scan and see the soft tissues collapsing. So the pros were natural sleep. You would see multi-level obstructions happening at the same time. However, there were financial implications of reserving the MRI machine for the entire night. And well, who wants to sleep in an MRI machine? So there was definitely some issues there. So when we come to the management, yes, all these are adjuncts. I would take them as adjuncts, with the exception of PAP therapy. PAP therapy should go hand in hand, which I shall be discussing about. And the last topic is my topic for the day, which is targeted surgery. You try and find out where the problem lies, and you really, really go and get it. So for your pre-op essentials, psychological counseling is a must because patients will have some sequelae after surgery. They will have some remnant snoring, sleep apnea. So you really need to get them on the right frame of mind and be absolutely positive about the entire implication. We really talk about pain because any form of surgery is painful, especially when we talk about your palate and your tongue. We discussed airway, fiber optic intubation, elective tracheostomy consent is a must, and we prepare for all sorts of emergency complications. So coming to the surgical management of static obstruction, I'm just going to run through a few videos. For your nasal surgeries, I mean, I really don't need to, uh, uh, everyone is a qualified ENT surgeon, and there's nothing new that I'm offering here. But the first video is a turbinate stitch, what we do, especially in our sleep apnea, because the turbinates are really quite floppy in these people. So if you just stitch them, you create a better airway, open up the middle meatus. Septoplasty, I don't think it needs any introduction or explanation. So it really helps when we talk about a static obstruction. Um, as an adjunct measure whether there is a visible problem or not, a turbinate reduction or channeling does help. So the first video, the video above is the concha bullosa, which is aeration of the middle turbinate, and we just do a lateral laminectomy, and that opens up the airway really nicely. And the video below is coblation assisted turbinate diathermy, basically, where you go submucosally and you ablate the soft tissues. That leads to a reduction of your turbinate, albeit it is temporary, really lasts for about 2 to 3 years. But yeah, that's all the time the patient needs to motivate himself to really get better. So for your adenoidectomy and your tonsillectomy, we prefer to use coblation, and the above video is a tonsillectomy, below video is an adenoidectomy. We like to use coblation, especially in sleep apnea, because these surgeries, while they are sufficient in itself in children, in adults, usually an additional procedure is required, and you really don't want any bleeding to happen. And the coblation does give you a nice clear vision. An additional point, especially in the tonsillectomy, while using the coblator, we leave the capsule in place on the tonsillar bed. And that really helps with all our modification, our suturing techniques, our resection techniques. It really helps a lot. So for that, yes, we like to use the coblation. Well, when we talk about your dynamic collapse, in my mind, there are basically four major uh, types of procedures, what you can do to take care of the dynamic collapse. You have your, and I'm sorry, I could not find any reference to this online or through literature. This is just something that I personally use. So they're the 4 R's. The first is the resective surgery. Then we have the restructuring, we have the remodeling, and we have the reinnervation. So I shall just be going step by step, trying to explain, trying to talk through videos. So the first and the earliest procedure which was done was the uvular palatoplasty, wherein the uvula, along with a portion of the soft palate, which is below the level of the levator and the tensor vela palatini, was basically cut away. Now you could really, really use anything there. And this just so happens there's a video where I'm using the coblation, but that was basically it. You would just do away with the entire segment that was collapsing or supposed to, uh, you know, have the maximum collapsible element, go to your limits of what was safe, and just take it out. So that was what was happening. But this would really, really not address the lateral collapse. This, of course, would not address your tongue collapse, and which was why we had a lower success rate when associated with this procedure. However, for the right indication, it is still a wonderful procedure, but it goes with a lot of morbidities. We have the zetaplasty as well, which is a modification of the UP3, where we just raise a few flaps and you suture in such a way to bring the palate up forward and above. So that would create dilated airway. Well, the surgery which has been in vogue is the base of tongue resection, wherein you would just excise again with any sort of instrument. This is again just coblation because we feel it is one of the safer methods because you're able to visualize your field. And you could really just reduce the midline of the tongue, especially the lymphoid tissue. You would really become quite careful once you reach the muscular layer of the tongue, because that's where your lingual arteries are. And this is quite a complex and a dangerous surgery because once the lingual artery opens up, there's really very limited ways you can control it. And so lymphoid tissue, not a problem. You reduce the base of tongue, you open up, you reduce, do a volumetric reduction. The patient really does quite well. But we have seen eventually almost 20 to 30%, these structures come back and we land up with the same problem. So if the epiglottis is the primary cause of concern during snoring and the epiglottis is just falling upon itself, the resective option was to just take off the supra portion of the epiglottis. You chop that off and the collapsibility decreases. The subsequent fibrosis of the remnant of the epiglottis also prevents any snoring. So that is quite a good procedure when we talk about a pure epiglottic collapse. When we come to the restructuring, that was really the next era. I think it was heralded by Dr. Kenny Bang, and where he brought upon the procedure, which is expansion sphincteroplasty. In this, the first step of the surgery is, of course, a tonsillectomy. This again, I'll just run through this video. You first do a tonsillectomy, and this is the end of the tonsillectomy. So once you have done the tonsillectomy, you basically section off a portion of your palatopharyngeus muscle right at the junction of the upper 2/3 and the lower 1/3. Once you do that, you take an absorbable stitch through this portion of muscle and you try to anchor it laterally towards your pterygomandibular raphe, which is a fibro-osseous hold. So this would really pull up the palate, the soft palate, pull up the entire palatopharyngeus muscle, and open up the airway laterally. So you would get an excellent lateral expansion at the end of this procedure. So you can see you just go back with the suture back and forth once or twice. And you can really see why we like to use the coagulation, because once you're doing the suturing techniques, you do have quite a good amount of bleeding. Now, for example, if you're doing a conventional and you had to cauterize this area, suturing would really become quite a hassle. So this is just the same procedure on the other side. Sorry. Modified Robinson's is another form where prior to this suturing, you would really, with a coagulator, you would just take off the submucosal fat and your minor salivary glands to just do a muscle-to-muscle suturing technique. You also have the tongue advancement procedures. We have the genoglossal advancement and the hired suspension. And there's just a video of the hired suspension. It's really quite a simple and effective procedure where we just make a small neck incision, isolate the hired and the thyroid cartilage, and just take multiple non-absorbable sutures through it. Usually we would take Prolene and just tighten them together. That would bring the hired forward, and as a consequence, it would just pull the the base of tongue forward with it. And with that, you would get a good retrolingual dilatation. For your genoglossal advancement, you just make a window in the front of your mandible. You excise the bone with a drill where the genoglossal is inserted, pull it out, rotate it 90 degrees, and just screw it in place. And that achieves the same effect. Now, this is quite a neat surgery And but it's really dependent on for how long the fibrosis and everything would last. Wherein I would now come to the next part, which is the remodeling. The simplest remodeling form is a lateral pharyngoplasty, where you would basically do a tonsillectomy first, and you would just suture the pillars together at the end of the procedure. Once you do that, of course, you try to incorporate the muscle within it. So you get your excellent lateral expansion right there. And this is one of the simplest methods, but it's really effective. Next, were the pillar implants, which were quite in vogue. I will be discussing the anterior palatoplasty in a bit. The pillar implants really never took off, but it was a wonderful procedure. It could be done under local anesthesia, and this is a patient being done under local, where this patient had a excessively long soft palate, a floppy soft palate. We would just vibrate, and the pillar implants were basically just inserted into the soft palate at an angle, and you would get these Teflon pillars, which would just provide stiffness to the soft palate and prevent its collapse. And you can just see we do one in the midline, one on each side, and it's a very simple, effective procedure. But however, it was never FDA approved, and not really, never really took off. I will be talking about the Barbed Roman blind suturing technique in detail, but the future also is the hypoglossal nerve stimulation, where there are a lot of people doing it in Europe, and it's still not approved in India yet. We are still waiting for it. We have a couple of companies based in the US as well, and with basically the patient would, whenever there would be a reduced chest movement or a drop in saturation, this there would be a hypoglossal nerve implant, which was done through a small neck incision in the submandibular region, and it would just give a small stimulus for the hypoglossal nerve to contract, and that would really bring the tongue forward and open up the airway and prevent apnea. So this part of the lecture I would like to dedicate to my mentor as well. I had the pleasure of working under him for almost 3 months. We had him here in India as well, Professor Mantovani, and I was introduced to the barbed suture palatoplasty technique by him, and he unfortunately passed away quite recently. So I would really like to dedicate this part of the lecture to him. So he put forward this amazing idea where we would use a barbed suture, which is basically a knotless, absorbable PDO suture, and we would really talk about lifting up the soft palate and anchoring them to various bony and fibro-osseous holes. The bony holes that he identified were your junction of the hard palate, soft palate. We had the pterygoid hamulus right here, and we had the pterygomandibular raphe. So God had given us basically a tube within the tube. If you could just stretch your imagination a bit, we would have the bony tube outside, and we would have the soft collapsible inner tube inside. Now, if you could just expand and hook these two together, we would reduce the collapsibility. So this is just running through the anterior-posterior collapse pattern. The first step of this procedure would be to do an anterior palatoplasty. Then after that, we will start suturing. I'm just going to run through it. We would just start from the hard palate, soft palate junction, go up to the periuvular palatopharyngeal insertion, come back, close the anterior palatoplasty, hook it up laterally towards the pterygoid hamulus, and then just run all the way back. And that would really, tent up the soft palate so as to reduce its collapsibility. And this is a video showing the same. Now I have modified the technique a little bit, but I'm just going to run through it. The first step is to, of course, mark out the structures, get your markings. The first step After that is your anterior palatoplasty, when a small window is made in the soft palate, basically in the middle 1/3. You start excising first the mucosa, then you have the submucosa fat and your minor salivary glands till you reach your muscle layer, and that's where you stop. After that, this is the Barbed technique. Start from the hard palate, soft palate junction, going down. Of course, because it's a barb, you do not need to take any knots, so the patient compliance is slightly better because the knots can be really quite painful. So we close the anterior palatoplasty site in layers, and this is an extra stitch which I was taking right to the pterygomandibular raphe. And the beauty of this technique is it can be modular. You can pick and choose where you want to place your sutures according to the findings that you find on your drug-induced sleep endoscopy. And this is basically what we have when we've completed both sides. We do not need to knot at the end of the procedure. You just cut the sutures where they are. And they stay in place because of the bark right there. And that's the beauty of it. So you've not violated any structure. At the end of the day, you see your uvula pointed back at me, which I like to call as the uvular salute, to say that you've done a decent, well, I hope a half decent job. Similar, we have, according to your dice pattern, if we have a lateral collapse, the suturing technique slightly changes. Of course, we do a tonsillectomy, but first we go laterally, just to get your bony and fibroosseous holes in place. After that, with your hard palate, soft palate junction, your pterygoid humbilis and your raphe, and then after that, you basically just take multiple sutures on your posterior tonsillar filler. Come back to your raphe, come back to your humbilis, then go all the way back. Just do the same on the other side. And it's really quite simple when you see it like this. This is a patient where, of course, there is, please forgive me for some edema there. This patient had some uvular injury during the surgery. Well, of course, again, the markings take place of all your anatomy. We again start off with the hard palate, soft palate junction right there. We go down, head towards our uvula. This was a patient where, of course, I wanted to take the periuvular tissue because the posterior tonsillar pillar was really, really quite bulky, and I wanted that upward pull as well. You can see the periuvular palatopharyngeus being engaged. And after that, you really come laterally. You try to engage the periosteum of your pterygoid humbilis to get that solid osseous hold. Once you've done that, you just travel in a swiveling movement along your raphe, try to get as much as of the fibers as possible engaged. Once you head down and you've completed your raphe involvement, then you just go laterally. This is me going through the anterior pillar. The next step would be to engage as much of the posterior tonsillar pillar muscle as possible. So this is just re-engaging the muscle once more and hooking all this laterally. So the suturing looks quite simple, but in the confined area, and especially in the case of sleep apneics, it can be a slight issue getting a good visualization at all times. It's definitely easier with a headlight, but of course we don't have the luxury of getting recordings then. So this is done under the microscope, and at the end, you can just see that you see the lateral collapse right there, if you can appreciate. I'm just going to run through the starting of the video. You see the bulky tonsillar pillars, and you see the end result with a good lateral expansion. The combination of these two techniques is basically the Alianza technique, wherein this is done for your concentric collapse of the retropalatal region. The first step is your anterior palatoplasty, and then you just start suturing. Again, from the familiar hard palate, soft palate junction, go back, periuvular palatopharyngeus, close the anterior palatoplasty site along the way, Once you've done that, head to your hammerless, then engage your raphe, complete your lateral expansion with the similar suturing, go back to your hammerless, and then go back to your hard palate, soft palate junction. Same thing repeated on the other side, and you get a good expansion, holistic expansion of your soft palate. Now I'm just going to let this is just a 2-minute video. I'm just going to let this run out. So this is the first step is your tonsillectomy, of course. We're using the coblation again. So the left one, the right one. Once we are done, using the coblator for the anterior palatoplasty in this, we expose the muscle, mark out bony landmarks and your raphe, and you start suturing. Me being right-handed, it's slightly easier to go on the left side first. But the first bite is basically hard palate, soft palate to your anterior palatoplasty, close it along the way, head downwards to your periovular palatopharynges, hook that muscle fiber right there, and try and come back towards your pterygoid hammerless, trying to engage the periosteum. Next step, going back to your pterygomandibular raphe, encircling the fibers, engaging the fibers as much as possible in a swiveling movement. You see the hand movement going right there. Once you go downwards, then you engage your posterior tonsillar pillar to really get that good lateral expansion right there. And you bring those sutures back right towards your pterygomandibular raphe. Make your way back to your hammerless. Try to engage the periosteum once more just to get a nice firm hold in there. And you make your way back to your hard palate, soft palate junction. And this is just me completing the procedure on the other side. Just cut the sutures at the end. And you can see that uvular salute sign at the end, where it's just looking up after the expansion, and you get a good anterior posterior as well as a lateral expansion. So the advantages of Barbed, according to me, well, it's modular. You can really do your suturing as and where you find the obstruction based on your dies. It is reversible because if the patient doesn't tolerate it, you can simply divide the suture and just pull it out. The barb really engage in one direction, the other direction, they can just pull it out. It's repeatable because, well, with a long enough experience in sleep apnea surgery, you know that these patients come back. They may not come back in 6 months. They may not come back in a couple of years, but they'll definitely come back within 10 years. So it's a repeatable process. You can obviously do that. It has a lesser morbidity because you're not excising or cutting or dividing any muscle. And there have been plenty of studies based on that, the long-term effects of cutting the palatopharynges. There are quite problematic issues of cutting the uvula as well. And the best part is it's based on multiple bony landmarks. There are quite a few procedures which are based on just the pterygomandibular raphe. Now, pterygomandibular raphe is a fibrous condensation. So it's really not going to be as good a hold as a periosteum of a bone, let's say. So once you have multiple bony landmarks, you're anchoring your soft palate to, the surgeon can have a better sleep at night. Well, coming to the last part, we do have the skeletal malformations which have to be treated. So whatever technique you want to resect, remodel, or reinnervate, if the problem is a small box where you have a smaller airway because of maxillar or mandibular hypoplasias or retrognathisms, well, none of these procedures are really going to work till you expand the airway. And once you expand, everything really opens up and you don't need to do anything else. So this is just a schematic diagram. I'll also be talking about the devices. The post-op essentials, of course, emergency tracheostomy it should always be at hand. In our center, we usually, whenever we do touch the base of tongue, we like to keep the patient intubated for at least 12 hours. Wait for the edema to subside, and only then should extubation be attempted with um, the preparation for a fiber optic laryngoscope as well as a tracheostomy on at hand during extubation. NPO state for 24 hours is a must because these patients are going to have swallowing issues. They're going to have mild aspiration issues after extubation. Pain and swallowing management is a must. I mean, we really, really counsel that pain is going to be a feature of the surgery for at least 4 weeks. Swallowing management, of course, it has to be calibrated quite slowly, and the patient should be encouraged liquids first, either with a straw, sorry, or going on later to soft diet. We generally, as a matter of protocol, we repeat a sleep study and assessment after 3 months to really categorize what kind of a result that we have given. Now, coming to just devices, I know this is not my topic, but I found it too interesting. So, especially in children, just on a side note, we do have your adenotonsils, but we do have syndromic children where we have maxillary and mandibular hypoplasias. Especially in chronic adenoid kids, we do see a high arch palate, we have crowded upper teeth. And these are patients where the maxilla really becomes quite hypoplastic. So devices are a very, very interesting and a good way to prevent, not prevent, or to treat sleep apneas and snoring in children who have this malformation. And of course, we take care of the future as well. So 8 to 15 is the ideal years are the ideal candidates. And we have two types. We have the removable, which is the first, and we have the fixed, which is the second. And we have the titratable ones as well, where you just use a key to basically, over the years, you just expand the maxilla. Similarly, we have the mandibular advancement devices. Works on a similar dental principle where there's a gradual distraction of your mandible to try and bring it forward. Once you do that, your tongue really gets out of the way of the airway, and these patients also do quite well, provide the indication is there. Now, these can be quite viable alternatives to your base of tongue resection techniques and your distraction techniques. However, these have a limit. You can only really get a slight amount of advancement before you start having temporomandibular joint problems. Just in a nutshell, just trying to summarize, we have a modular treatment strategy, and this is a flowchart that we used to use quite a long time back, where surgery cutoff would be a BMI of 30, and your lower the AHI, the better your results. Mild, moderate were the ones who were taken up for surgery, maybe just to beef up our surgery success rates, trying to compete with the gold standard, which was CPAP at the time. And in children, if you see adenoid tonsils, you would straight away go for surgery. Any other problem, giving, let's say, a 10-year-old child CPAP, are we doing him or her justice? No. Well, in the end, this really is a complex disorder and a multidisciplinary approach, which includes the sleep physician, your chest physician, your dentist, your ENT surgeon. Everyone should really work hand in hand to manage the patient who's really suffering. And CPAP and surgery are synergistic and complementary to one another. Just as almost all the ENT surgeons, once we have a patient with a conductive hearing loss, the patient has the option of a hearing aid throughout life. But on the other hand, we can do a simple surgery, which is stapes, and cure the patient. So there are exceptions, but we need to work together. And just to sign off, every patient is different. We need to look at every patient as an individual, as a different individual, and treat them differently with whatever tools you have at hand. And I would like to sign off with this wonderful quote by Shakespeare. And Thank you so much.
I find it very educational. Many thanks for that.
Thank
Do you mind if I start with my first question? I'm not sure if you know or not, in the NHS, we're a bit tight with money. We're a bit limited in what we can do in terms of snoring surgery. Partly of that is there was a question about the long-term outcomes of snoring surgery. What are your thoughts about that? Do you have the same problems in India? How did you navigate it? What was your thought?
Well, according to every literature source, I mean, success of surgery for snoring is basically reduction of 50% in the AHI score, right? And that was really the yardstick by which we would judge surgery. But really, that's not the case. Uh, Nowadays, we do our repeat questionnaires. If you could really improve the quality of life of the patient, I think that's far more important than some objective measure like an AHI. The more important index, in my opinion, is to raise the baseline oxygen saturation, because that really prevents any long-term sequelae. Because once you have that, if you can improve that, a patient who has a 60% baseline during sleep, if you can bring it up to 80, 85, well, the recommended is 92. However, if you can bring it to even 80, 85, that's good. In addition, we counsel all our patients that, apart from the static obstructions, your tonsils, adenoids, where you can literally cure the patient, right? Rest of the surgeries are adjuncts. They are meant to be uh, a cure in just a few, but they're meant to be adjuncts to their CPAP therapy. So we always give the patient a CPAP trial before. If the pressures are too high, the physician sends them to us. They undergo some sort of surgery, wherein we can bring the pressures of the CPAP down to increase the compliance. So it's a mixed bag. I mean, success rate, it's relative.
That's true. That's true. And do you manage to get some of these patients off the CPAP with?
Well, yes. So, for example, one of the patients that I'd shown, especially the Alianza Barbed technique. Now, that patient is off CPAP. He was on CPAP and he was, I think, on pressures of 12, if I'm not mistaken. I'm sorry, might be wrong. But he was off CPAP and his AHI dropped to 6, which is still, well, in the mild category, but he really did not need the CPAP after that. Well, after that, he went to his weight loss regimens and lost a lot of weight. That helped. So.
Great, that's good to know. So a few questions from the attendees. A question from Andrea. Does the barbed treated patients have nasal regurgitation?
Well, hi, Andrea. That's a wonderful question. Well, really, if the regurgitation happens, it's going to be temporary, because once it's never going to be permanent, because you're not cutting anything. The tissues are going to remain where they are. And I personally, after having, I've done about 25 of these cases. I've never had it personally, but according to all literature, yes, it can be transient in nature.
Great, that's fantastic. The question from Kian Kumar, I'm not sure, maybe you can elaborate on what this, Kian, is DISE. Is that something you guys use?
Yep.
And has anyone done post-operatively in OSA patients? Perhaps you can tell us what is DISE?
Oh, that's the drug-induced sleep endoscopy. In the we're talking about DICE in the post-operative period.
In post-operatively, yeah.
Well, I don't think that's really indicated, because why take the patient to the OR once again unless and until he has a problem? If he has a problem, or if there's a huge failure of your surgery, then of course it's indicated. Otherwise, the awake fiber optic laryngoscopy with all your maneuvers in the OPD is as good a diagnostic tool. A sleep study is mandatory, at least in our institution, but a DICE, no.
And do you have any indications for DICE preoperatively in your institution?
We always do that. That's a matter of protocol. We always do a DICE before taking up for surgery, to try and understand exactly what's going on and not rely on indirect measures alone.
Okay, great. Question from Mohammed Moyes. If you have a deviated nasal septum and the patient doesn't have sleep apnea, do you address the deviated nasal septum first, or do you try CPAP first?
So I think the question is really about this, your single stage and your multi-level surgery, right?
Yes.
So earlier it was propagated that you could do two major sites of surgery and one minor, wherein the nose would be a major, of course. You would have your palate or your tongue or your epiglottis. So these are the four major. And you could do a minor procedure, which would just be a channeling or your diathermy. And you would really do 2+1. But now there's enough evidence in literature that you can go ahead doing a multi-level. Me personally, if I'm doing the nose, I would not touch the tongue, because nose I would have to pack in all likelihood. And if I do a tongue base and that area undergoes a lot of edema, it's really, really uncomfortable for the patient and for the surgeon as well to manage that. So,
Okay.
so tongue I would do as a second stage in almost any situation.
So you stage your surgery to the nose and to the palate separately.
Palate, your epiglottis, everything is fine, but tongue I would do separately. That's
Okay.
my personal preference.
Good. A question from Mariam Shadi. If you have a singer and you're doing snoring surgery for that singer, do you wonder about vocal tract resonance change? Does it affect the resonance in your experience?
Well, yes, it definitely does.
Hmm.
So these are things that you have to really, really get clear beforehand, because you could have a huge lawsuit on your hands if you spoil a singer's voice. The resonance is really, really important to them.
Right. And a question from Dr. Sudrasan Sin. Could an orthognathic surgery speed up the treatment for the patient instead of advice on activating it daily?
Definitely, that was what I was touching upon at the end. Your advancement procedures, your maxillary and mandibular, they're really, really wonderful. I personally, being an ENT surgeon, those things are being taken care by our oral surgery department. So I personally don't have videos for those procedures, but they're really, really beneficial if done for the correct indication. If you really have a good, normally placed maxilla or a mandible, you can't really advance it too much before you cause a problem. So, I mean, there's a fine balance. It has to be indicated, but that's really nice.
And question from Mustafa Ali, minimum age for barbed palatoplasty? Do you have any in mind?
We're talking about Barbed, right?
Mm-hmm.
Yeah, the minimum I have done is 4 years. So,
Okay.
yeah.
And from your experience, how common is velopharyngeal insufficiency in UPPP?
Well, according to literature, it's not much, as long as you stay below the level of your levators. But in actual practice, there is some nasal regurgitation in about 30 to 35%.
Okay.
So,
And
yeah.
that's usually temporary?
Well, yes, usually yes. As long as you stay below that level, which I'm sure most of the surgeons would, it's usually temporary as well.
I think that's similar. Asked the same sort of, Mariam Shadi asked a similar question about hypernasality and velopharyngeal insufficiency, so along the same lines. A question from Star Wacy, and any indication for posterior pharyngeal diathermy?
We did not really find too much of use, because what you basically, it's really, really thin muscle layer anyway in your posterior tonsillar pillar. So doing diathermy there is really not achieving too much. So it's either you're cutting that muscle, dividing that muscle, or you're resecting, or you're remodeling it in some way. Just doing a submucosal really does not. We did not have, at least personally, we did not have encouraging results.
And from your experiences, do you find, is there much of a difference? Like you mentioned, tonsillectomy is the main aspect if it is tonsil hypertrophy contributing factor, and then the other maneuvers are sort of adjuncts. In your experience, if you find one adjunct, one of these maneuvers particularly more useful than the others, that you would sort of your go-to for palatal side of things?
No, it really, it's whatever the situation demands. Like, let me just take an example. Okay, tonsillectomy is the cornerstone. You have to take out the tonsil when you're talking about sleep surgeries, right? Now, after that, when you concentrate toward your palate, um, and let's say you have a concentric collapse, let's take the worst case scenario. If your palate is collapsing, but it's thin and there's not too much of muscle bulk, then I would go with the barbed, right?
Mm-hmm.
If there's a lot of muscle layer and the muscle is itself quite bulky, then in my personal experience, the suturing is not the best. Then I would do the expansion sphincter or palatoplasty plus your anterior palatoplasty, right? Then if you really find that the soft tissue is just too redundant, you have a lot of uh, mucosal hypertrophy of your soft palate. You see your muscle layer right here, and you see your mucosa heading almost a centimeter half down. Then that probably, in my mind, is the indication for a modified UVPP. So it's quite a dynamic situation, and again, there's not one clear uh, thing that I can advise if that helps.
Sure. So a couple more questions. So one, I was asking, where do you, are the your videos, are your own videos, or are they available on the internet?
Well, apart from the animation, they're all ours. So
They're all yours as well? Okay. So I suspect maybe YouTube will have something about the barbed procedure technique if you want to educate yourself with that. And maybe perhaps last couple. So one of them is just going, when are you going to repeat the barbed procedure after the primary procedure if you do need to repeat it?
okay, so in theory, these sutures, what we're using, the PDO sutures, they're supposed to dissolve at the end of 6 months, right?
Mm-hmm.
Now, in that in the intervening period, they become really quite integrated with soft tissue. So 6 months, absolutely no. After that, you have to give it time to develop fibrosis, because what you're really doing with these sutures, it's not just the sutures which are pulling, it's a directed fibrosis of the submucosal and your muscle layer, which will eventually tent up those soft palatal um, soft tissue and prevent its collapsibility. So you have to wait the fibrosis to step in next. Uh, so that takes about a year and a half. So you're good to go for at least 2 years. Till now, I personally have not had to repeat, but I had a huge talk with Professor Mantovani when I was there. And he said, well, give it 2 years. After that, if you still feel that, you know, it's not working, then go ahead and do it. So that was his word.
No, it works. Okay. And then a question from Kian: Would you choose between dice or sleep MRI? What would be your preference?
Okay, in our center, sleep MRI is virtually impossible because our hospital, um, our MRI machine is barely free. They won't give it to us for 12 hours.
Hmm.
Sending a patient outside, it's well not feasible. So we prefer doing the dice. And of course, being surgeons, we would like to see ourselves what's happening. Holistically, when we're talking about multi-level obstruction, because the situation is really quite dynamic, ideally, I would like to have sleep MRI, but that's just not possible for us.
Okay, great. And then the last question, and it'll be a good one to end with, is from Tashita. What is your advice for a junior surgeon who wants to pursue sleep medicine and sleep surgery as a career? How to go forward?
Well, well, well. Apart from this virus thing, which has just happened recently, and there's so many fellowships up and about, and they're wonderful. In our country itself, we've had this has we have this association for sleep surgeons, and we offer fellowships where we take 2 fellows a year, and they undergo training around the country at various centers. Our center being one of them. So I would suggest, fellowships are the way to go. There are a lot of cadaveric dissection courses which are now being offered as well, which really help you get the feel of things. And well, as with any surgery after that, just You'll just have to take the plunge and get onto it.
Very true. That's kind of goes with any surgery, really. Well, Varun, I only have time to thank you really for your wonderful talk, and appreciating your time, particularly this late at night. I'm sure it's way past the bedtime for most people, maybe not for you, but for most people it's past the bedtime in India. So I'm really grateful for your time, and thank you very much.
Thank you. Thank you so much for having me. Thank you all.
Have a good night, everybody. Bye-bye.